you so much. And I would like to thank all the participants for joining us. And I typically give these talks in person, of course, and with COVID, we have entered this brave new world. And it's somehow not the same being able to look at a computer and give a talk. That human interaction definitely adds to the quality of the presentation. But I'm hoping to be able to do as good a job as possible. And I want to thank Mercer County Surgery Center, which I consider as the premier institution in the local area for surgery centers, for giving me an opportunity to give this talk. All right, and of course, we have to take COVID extremely seriously. And as you may be following the events and especially the Johns Hopkins University numbers, unfortunately, more than 117 million people have been documented to have contracted the COVID, and we have lost close to 2.6 million people worldwide so far. And in United States, about 29 million people have been confirmed to be COVID positive, with the most recent death totals roughly a couple of days ago being at 427,000. While these are numbers, we obviously understand that COVID has literally changed the way we live. It has touched many facets of our lives. And I believe this to be the largest life-changing event, definitely from a medical perspective, but also in our day-to-day living, our grocery store, school, travel, so on and so forth. And while COVID definitely deserves the attention that it's getting, we need to understand that the rest of the health problems don't stop. Next slide, please. So to get a perspective, and this is something I looked up for the sake of the talk, and even I have to say, being in the medical field for over 25 years, it was pretty stunning for me to look at some of these numbers. Total number of deaths in the world, 60 million per year. And these are numbers from 2020, and obviously since over the last 2.5 months, we have unfortunately lost many more people here in the United States. So roughly 410 deaths in the United States in 2020. And for comparison, we lost about 655,000 people to heart disease and close to 500,000 or 600,000 due to cancer. In other words, we need to continue to pay attention to the rest of the illnesses so that we can provide as best a healthcare as possible. On the other hand, we also know that people in overall good health have a good outcome with COVID-19, and if they have comorbid conditions such as heart disease, emphysema, and cancer who are on chemotherapy, they tend to have a much worse outcome with COVID. And that's why it's important, as we pay attention to COVID with all our might, that we don't forget other health issues. In other words, protecting ourselves against cancer is another way of protecting ourselves and our families against a bad outcome with COVID. Now, at our surgery center, we're taking every possible precaution, primarily to protect our patients. But of course, we need to protect ourselves, because it's so happened that when in certain hospitals or surgery centers, when a lot of people got diagnosed with COVID, they had to shut down the center for 2 weeks or longer. So every single day, the moment we walk in, right at the door in some of the hospitals, but here, as soon as we enter, every employee is screened with a questionnaire, temperature check, and oxygen saturation. At this time, pretty much all of us at the center have received 2 doses of vaccine. Obviously, it protects us, but it protects the patients as well. And if any of you have had a colonoscopy or an endoscopy recently, you know that 2 to 3 days before you come into the center, you have to be proven COVID negative by nasal swab. And from the time you get the test to the point you have the procedure, you need to quarantine yourself, which minimizes the risk of you catching COVID in between. This is a sad part. Unfortunately, visitors are not allowed to come into the center. It's not good for the patients in terms of how comfortable they feel. It's always better to wake up to a loved one next to you when you are waking up from the sedation after procedure. But the reality is we can't control the health status of the visitors as they may change from day to day. So at present, unless the person is a minor, or if they're disabled, no visitors are allowed. And the best part is, thankfully, to date, there are no reported cases of COVID transmission at our center, and we're very happy and proud of that. And talking of pride and our Mercer County Surgery Center, I'm delighted to report to you that though we have been at this location for roughly 2 years, we've already been ranked #1 in New Jersey by US World News and number 15th nationwide. And I am also delighted to tell you that no other surgery center in the area has received this commendation. You may look at this slide and say, wait a second, this was supposed to be a talk on colon cancer. And why is it that we are seeing all these pink ribbons? And there is a point that I want to make, okay? As we go through the rest of the slides, you will realize the implications and the importance of colon cancer. But you can hardly buy any product in the United States without a pink ribbon. And I don't say this in a negative way. I say this out of respect as to what a fantastic job the breast cancer awareness groups have done in terms of getting support from major NFL teams, airlines, the White House, and practically every product on earth, including cigarettes that have been implicated, at least to a small extent, in terms of causing breast cancer. This is sometimes when I miss the interaction. Typically, I would be asking, does anybody know what the color of the ribbon for Colon Cancer Awareness Month is? Maybe 1 or 2 hands would go up, and most people would not know what it is. And I have to say somewhat shamefully that many people in our own office didn't know the color of the ribbon for Colorectal Cancer Awareness Month. It's blue, but it doesn't necessarily get even 1/10 of the attention that the pink ribbon gets in the media and with retail stores, okay? But the key is colon cancer, while obviously no cancer is good, relatively speaking is preventable, treatable, and beatable compared to a lot of other cancers. And that's why raising the awareness, and as we will see, both prevention and early treatment makes a huge difference, and we'll spend a bulk of the time of this talk on those 2 issues. So for example, for comparison's sake, in terms of breast cancer, which sometimes it seems like it takes up all the oxygen in a room when it comes to cancer awareness, colon cancer is the second most common or biggest cancer killer in the United States. Unfortunately, we still lose about 50,000 people per year due to colon cancer. On an average, in spite of all the advances that we have made, 1 in 3 people who are diagnosed with colon cancer will eventually die. Breast cancer, while unfortunately it's still very common, 1 in 6 women who are diagnosed with breast cancer will eventually die, or there is close to a 80% overall survival rate. Now, this number you will see frequently in different contexts as to what's the lifetime risk of developing colon cancer. In this one, they use the word 1 in 12 people will develop bowel cancer, which includes the entire GI tract, including the esophagus, the stomach, and the colon. And as a result of it, that is calculated at being 1 in 12, okay? On the other hand, as far as colorectal cancer itself is concerned, which is the main focus of the talk today, The estimates are somewhere between 1 in 16 to 1 in 20 people that will develop colon cancer in their lifetime. Obviously, still something exceptionally important because most of us have a family of between 15 to 20 people. So unfortunately, in our lifetime, we can expect one family member based on this statistics to develop colon cancer. And even a small business can have between 60 to 100 people. So this disease can strike close to home, which is why we had to pay attention to this. So this is just a summary slide of colon cancer to, in a sense, grab your attention. As we already discussed, it's the second most leading cause for cancer death in the United States. And I've already mentioned this number of 1 in 16 to 1 in 20. That's the number of people who can expect to be diagnosed with colon cancer in their lifetime. Up until now, 50 used to be the cutoff to start screening. And as you may have noticed, unfortunately, colon cancer is striking younger individuals at a higher pace. And unfortunately, younger the person is at the time of diagnosis, higher the risk of mortality. In other words, people who develop colon cancer at a young age tend to have a more aggressive disease, okay? If there should be a family history, that risk of developing colon cancer is about 2 to 3 times higher than that of the general population. And what that means is if somebody has a family history of colon cancer, their risk of developing colon cancer may be about 1 in 8 or 10 individuals, okay? That's why family history becomes so important in terms of them having to get screened for colon cancer. The good news is we are making progress. And as of the last census, more than 1 million people who were originally diagnosed with colon cancer are still surviving with us. And we are thankful for that we're able to save so many lives. So this is one of the arguments. For example, nobody likes to have a colonoscopy, and unfortunately, we have to get it at some point in life. One of the biggest arguments that we come across as a point of resistance by patients is, well, I don't have a family history of colon cancer, so I don't think I need to get a colonoscopy. Well, this is the truth, okay? Only about 33% of people who are eventually diagnosed with colon cancer have a family history of colon cancer. In other words, of the roughly, as you'll see in the future slide, about 150,000 people diagnosed with colon cancer every year, close to 100,000 of the patients diagnosed with colon cancer are the first member in their family to develop colon cancer. And that's why it is important to screen people across board. While we pay attention to people with a family history, we can't ignore the rest of the community. It's thankfully not all doom and gloom. With a lot of cancers, unfortunately, screening doesn't exist because screening is either not practical or helpful. Pancreatic cancer is a classic example of that, where unfortunately we still lose about 28,000 people per year. But the disease process is so quick, there's no way to screen those patients. Thankfully, in terms of colon cancer, it can take somewhere between 5 to 10 years, and we'll go through this part a little later, 5 to 10 years for colon cancer to become significantly, clinically significant and or dangerous to their health. And with appropriate screening, we could reduce the mortality, which at present is roughly about 45 to 50,000 per year, by an additional 60%. And that's one of the reasons why we need to pay attention to it. One, it's important, and two, it's effective. So you can have a better combination than that when it comes to screening. So this is the number, and each year they keep track of the total number of cases. It kind of goes up somewhere between 147 to 160,000 new cases of colorectal cancer. And we try to specify new cases because Many people who have had colon cancer surgery and chemotherapy can unfortunately develop a second cancer at a different location within the colon. But we are talking only about new cases. In other words, they have never been diagnosed with colon cancer, and for the first time in their life, they are being diagnosed. And to kind of put that into perspective, Chicago Bears Stadium, which is one of the largest stadiums in the United States, holds about 61,000 people. And you can see, unfortunately, we can fill up the stadium 2.5 times in terms of the number of new cases per year. Another misconception is that somehow colon cancer affects only men, and we're not quite sure why this myth came about. And as a result of it, women who in general are very good at taking care of their own health would not undergo colonoscopy, but it's unfortunately what we call an equal opportunity disease. It affects men and women almost equally, roughly about 72,000 women per year and roughly 78,000 men per year. And those numbers can go up and down a little bit, but the point is women are just as likely to develop colon cancer as men. So screening is important both in men and women. So I've been trying to give you some positive news as well. And the silver lining is over a period of time, we have definitely made progress in terms of survival. Back in 1975, only about half the people who were diagnosed with colon cancer would survive. In other words, by current numbers, we would be losing about 75,000 people per year to colon cancer. Thankfully, survival has increased to 67.2, but it's still shameful that we lose about 50,000, but for what it's worth, we are saving an additional 25,000 people per year. This is a very important slide and a concept. Also tells us why we should not be postponing screening, okay? If colon cancer is diagnosed at stage 1, survival is a little over 90% or 94%. And unfortunately, if there is a delay in diagnosis for any number of reasons, you can see a progressive drop from 94 with stage 1 to 82 with stage 2, 67 with stage 3, and 11% in stage 4, okay? And that's why early screening is so critically important. All right, so for us to understand any disease process, what we have to understand is what's normal, what's abnormal, okay? I mean, here, clearly what's abnormal is colon polyps or colon cancer, but the process from which a normal colon develops colon cancer, that's what we will understand in the next couple of slides, okay? So the colon has several parts, begins on the right side where appendix is attached, which is called the cecum. Right side of the colon is called ascending colon. The part that goes across from right to left is called transverse colon. And on the left side, there are 3 distinct parts. The main portion, which is called the descending colon, an S-shaped loop called the sigmoid colon, and eventually way down in the rectum, which is the storage organ for stool before evacuation. So the important thing for us to understand is microscopically, the colon has 5 layers. It's the innermost layer, also known as the mucosa, that gives rise to colon cancer. So you can look at mucosa as a continuation of the lining of the upper surface of our mouth, or what's called the palate, the smooth, shiny pink layer that you see. The same lining goes from one end to the other, okay? This layer contains glands. You know, glands are necessary within the GI tract so that it can produce a lubricant so that the waste material can move smoothly. The base of the gland contains new cells, and the top of the gland contains the oldest cells. Cells on an average last about 120 days. And then once they die, they fall, they mix with stool, and they become part of the waste material. And new cells come from the base upwards to the top of the gland. And unfortunately, what happens is as we age, some of these cells, instead of one cell coming to the surface when one cell dies, two cells may come to the surface, because with age, a lot of things don't work correctly. And now the problem is two cells become four, four becomes eight, and that's why there is multiplication out of control. A tiny growth is called a polyp, and if unchecked, that can turn into cancer. So that's why it's important for us to be able to catch this when it's early and remove it. So we'll talk about that in the next slide. So this is what's known as the colon polyp to colon cancer sequence. Now it's a very well understood and established concept in the world of gastroenterology. But back in the 1950s, when this was described, it was revolutionary because it was one of the first concepts that helped us understand the formation of cancer and how to fight it. So as I told you, the normal lining is smooth, shiny, and moist because of the lubricant or mucus that it produces. So you can kind of look at polyps as the tiniest at the size of a sesame seed. As it gets larger, a pea, much larger, a peanut, and when it's really large, the size of a walnut. The lumen, or the inner diameter of the colon, is approximately 3.5 centimeters, okay, or centimeters. When you have a tiny sesame-sized growth or even a peanut-sized growth, it's easy for you to understand why there's no blockage, and unless there is significant bleeding, there are no symptoms. Unless the tumor spreads into the area of the muscles, blood vessels, and nerves, they don't get any pain, which is why, unfortunately, the early stages of colon cancer can fly under the radar for years. It is unfortunate, but sometimes we see patients with a tumor growth that has completely blocked the colon, and up until a week ago, they had no symptoms at all. Another important point to learn is you don't wait for symptoms before getting screened for colon cancer. So at the size of a pea, which is roughly about 10 millimeters in size or less, there are no abnormal cells, and those are completely benign, and if removed, we prevent colon cancer. And even if there should be abnormal cells in a polyp the size of a peanut, which is roughly about 15 millimeters, there's complete cure just with a colonoscopy and removal of the polyp. It's only when the tumor spreads into the wall of the colon that it can break through a blood vessel and start spreading. And the key for us is to try and get to the growth before it can hit approximately an inch in size. So, this highlights what are some of the risk factors. For example, we all know that smoking is a risk factor for lung cancer. Similarly, there are several well-established risk factors for colon cancer. Red meat, processed meats, animal fat, excess amounts of alcohol, and being obese and or excess body fat. So those are factors that increase the risk for colon cancer. Increased physical activity or a lean body mass, whole grains, fiber, and cutting down on animal meat, especially red meat, to no more than once a week. Those factors have been shown to decrease the risk for colon cancer. So, I've kind of said this in a different way. Stage 1, 90% survival. The best thing to do, of course, as we will stress later, is to avoid or prevent colon cancer. But unfortunately, if somebody should develop it, early detection carries a 90% survival, and that's where we need to pay attention. Unfortunately, when patients have early stage polyps and or cancer, they have no symptoms. So the usual resistance is, well, I feel fine, so leave me alone. So what are some of the symptoms that we should be watching for? Blood in the stool is a big one. Presence of blood in the stool especially in somebody over the age of 40, we are obligated to prove that they don't have colon cancer. As the tumor grows and encroaches the lumen of the colon, or the passage is the commonly used word, as the passage gets smaller, there's a partial blockage and backup of stool, so they can develop a change in stool shape. Some people say I have a ribbon-like stool or pencil-like stool, unexplained constipation, cramping of the abdomen because of the partial blockage, backup of stool, distension, decrease in appetite, and weight loss. So those are some of the things that people should be watching out for initially. So now comes the concept, okay? Of course, if unfortunately somebody should develop any form of cancer, they need to fight it, they need to battle the cancer as bravely and as practically as they can and try and beat it. On the same token, a person who doesn't have cancer doesn't say, I would love to battle colon cancer. Said no one, right? So the key is colon cancer prevention. And thankfully, unlike a lot of other cancers, we are actually able to prevent colon cancer. And that's what we should be paying attention to, and it should become our shared goal. And the reason I want to stress this word prevention, because when it comes to screening, we have what's called a menu approach. There are several tests that are available, and after appropriate information, the patients can pick and choose what they think is most effective or convenient to them. But we will focus on which one of the tests can actually prevent colon cancer and which one of the tests help with early detection. Early detection is good, but prevention is much better. All right, so now let's look at the disadvantages of prevention versus battle, okay? So prevention, as we will learn a little later, is best achieved through a colonoscopy. The downside of prevention is for people who have undergone a colonoscopy, you will understand, it is 1 day of a liquid diet, and of course, the inconvenience of taking the bowel prep. The large volume makes it difficult for them to be able to drink the prep. And of course, you always need to have a light moment. The prep is going really well. I've lost like 5 pounds. So there is at least a temporary advantage. Nobody would recommend a colonoscopy prep for long-term weight loss, but we need to have a little levity in what is otherwise not a favorite thing for a lot of people. So let's pretend that for any number of reasons, somebody doesn't go through screening, and unfortunately the colon cancer has already established. And we also know that unfortunately sometimes younger individuals as young as 30 or 40 years old who are way below the guidelines for screening, they can unfortunately develop colon cancer. And that, of course, unfortunately at that time, they have to battle the cancer. What are the downsides of the battle? Clearly, they will need a portion of the colon removed. Colon is not an essential organ, but still, it's a matter of going through surgery, the pain, and a short-term disability associated with it. And unfortunately, in some patients, after the tumor has been removed, the colon cannot be attached. It's called primary anastomosis. So they need a bag. If you're familiar with the term colostomy, they have to wear a plastic bag on their left lower abdomen where all the stool accumulates, and they have to empty the bag 2 to 3 times a day. Obviously uncomfortable from a psychological perspective, but for people who need to do it, they are brave enough to have to do it so that they can survive. A majority of these people are eventually able to get rid of the bag or the colostomy bag in approximately 3 to 6 months. Battling cancer also means they have to use chemotherapy, or they have to be on chemotherapy. The hair loss that may be associated with it, diarrhea, aches and pains, drop in white count, decrease in immunity, and risk of developing infections as a result of chemotherapy. And either from surgery or chemotherapy, there may be temporary disability, and unfortunately in some people it can lead to severe neuropathy, and they could even lose their ability to have to walk. And unfortunately, as we have learned, roughly 50,000 people die battling their cancer every year. So the reason I spent a little extra time on this slide is for us to know prevention is definitely a whole lot better than cure, and or in this particular context, battle. You can hardly watch a half an hour show these days without seeing that cute little box that walks up the steps and into the bathroom, and out comes the result. Okay, so we call it that cute test in a box, and it is popular. About 1 million people used it last year. It clearly has its utility in somebody who's elderly, may have bad heart disease or lung disease or kidney disease, and they cannot safely undergo colonoscopy. For them, this is a very valuable test. Unfortunately, some, or I have to say a lot of people who are in their 50s are beginning to choose this test. So let's try and understand what's the difference between a colonoscopy, what's the information we gather to be able to help you, and what's the information we gather from Cologuard. Okay, some downsides of the Cologuard. The advantage, of course, is you don't have to have a prep. You don't need to take a day off. You don't need the IV and anesthesia and the alleged risk of perforation. And of course, for a person in whom perforation happens, it's real, it's devastating. But I have to tell you, while we talk a lot about it, the risk of perforation in the real world is exceptionally low. I've been doing this for 25 years. I've probably done well over 50,000 procedures, and I've had 2 perforations in 25 years. Okay, so when you look at the hundreds and thousands of lives saved, and thankfully also both those patients, they had the appropriate surgery, they survived, and they did well. So the point is, the downside is not as much as we fear it is. But with Cologuard, 1 in 13 people with colon cancer can be missed, and that is, or that can be devastating. And as you will see with colonoscopy, one of the reasons it's so effective is because of detection of small polyps and removal of polyps, which decreases the risk for cancer. With a Cologuard test, if it comes back positive, which it does in roughly 1 in 3 people, the only way to make sure if it's a false positive test or if in fact to have either a colon cancer or colon polyp is to have the real colonoscopy and have the polyp removed. So in other words, you end up getting a 2-stage test. The trouble also is not only are there false positive, by which I mean the test comes back positive, and when you do a careful colonoscopy, you don't find any problem. You also have what are called false negative results. This is even more dangerous than a false positive test, because these are people who have polyps, some of them advanced precancerous polyps, where the Cologuard misses the diagnosis. In small polyps, about 30% or 1 in 3, and with larger polyps that may become cancer soon, almost 60% of them are missed, which is why we need to accept this test with a grain of salt. And if it's not in somebody with advanced other comorbidities, it's not an ideal test. So here is a comparison between colonoscopy, Cologuard, and another stool test, which is called the FIT test, that looks for presence of traces of blood in the stool, along with some immunohistochemical stains. We don't need to go into the technicalities of it, but the important thing to know is that while a colonoscopy picks up somewhere between 86 to 95% of precancerous polyps, Cologuard does so only in about 40 to 45%, and the stool test in only about 25 to 30%, which is why colonoscopy is considered the gold standard. We'll spend more time with it in the next slide. So when the procedure is done, the day before, patients had to be on a liquid diet, and they can have clear liquids all throughout the day, and typically later into the afternoon to early evening, they develop they had to mix the drink and drink the prep. They had to go to the bathroom multiple times till they're completely cleaned out. On the day of the procedure, they come to the surgery center. First, the nurse talks to them, the anesthesiologist talks to them to make sure that it's safe for them to have the procedure on that day. And the entire approximately 6 feet of the colon is carefully examined for the presence of any growths that are called polyps. And as we have learned previously, polyps, if unchecked and if they continue to grow, when they hit about an inch, they turn into cancer. So our goal is to catch it before it hits half an inch and remove it. So as I've said, for us to be able to prevent colon cancer, realistically, the best test, and to this day, it's still considered the gold standard, is a colonoscopy. And one of the reasons we're able to prevent it is identify the polyp, remove it at the time of the procedure. And removal of polyps has been shown in studies over the years to decrease the risk of colon cancer in that individual by close to 90%. So this is typically how we remove the polyps during a colonoscopy. Once we identify a polyp, and this is a special type that has a stalk. Not all polyps have a stalk, but be that as it may, we are able to put a wire loop around the polyp. We are able to pass electricity through the wire, and using that, it acts as a cautery with a knife, and we are able to safely cut. We are then able to catch the polyp using either a basket or just suctioning it through the channel or the scope. Every polyp that's removed gets sent to the pathologist for evaluation. We are able to identify which are precancerous polyps and which are completely benign polyps. All right, so in summary, okay, we got just a couple more slides, but as I've said before, it's the second most common cancer killer in the United States. Lung cancer is unfortunately still number one by a long shot, with about 150,000 patients diagnosed with colon cancer every year. Lung cancer is about 450,000 per year. So, and the survival rate is much lower with lung cancer. So lung cancer, unfortunately, continues to be the number one cause for cancer death in the United States. The good thing about colon cancer is, especially if found at an early stage, as we have said, 90% survival rate. Things in terms of the screening rate have improved. Roughly 20 years ago, only about 44% of patients who required a colonoscopy would get it. Now, thankfully, there has been some media personalities who were unfortunately afflicted with colon cancer. And some of the younger people may not remember, President Reagan had colon cancer. He had surgery and successfully survived. That is, to the best of our knowledge, the first. Of course, he was both a movie personality, but by the time he was diagnosed, he was already our president. Awareness improved at that time, and since then, many TV and movie personalities have put in a lot of effort to educate people, and we appreciate that. So up until now, age 50 used to be the age at which screening started. And unfortunately, as I've said, younger and younger individuals are now being diagnosed with colon cancer, and screening has to start at age 45, not age 50. Colonoscopy continues to be the gold standard. Identification of polyps and removal decreases the risk of developing cancer, which is why colonoscopy is a preventative measure, whereas the rest of them don't prevent colon cancer because they identify colon cancer. Nobody wants to develop colon cancer and then battle it and then end up with a colectomy, colostomy, chemotherapy, and other complications associated with it. We should focus on preventing cancer if at all possible. And once again, hopefully small talks like this and involvement of the community will eventually help spread the word. We are not as effective as the prevention for breast cancer movement is. Here it shows a stadium full of people, and the attention it rightfully gets, both from media and from sports and movie personalities. In terms of colon cancer awareness, one of the tools that has been used is almost like this inflatable plastic tent that can move from city to city. And on the inside, it shows the growth of a polyp eventually turning into cancer. And that has definitely helped the awareness. And one more, you can read this for yourself, okay? I hope you learned a couple of things. I hope you enjoyed the talk. And I once again want to thank all of you, and especially Jen Carroll, who's been very helpful to me in terms of formulating the talk. I know a little bit about technology, but I'm not tech savvy, and she was very patient with me, taught me all the steps. And Jen, I appreciate your help. And I want to also once again thank Mercer County Surgery Center for arranging and sponsoring this talk. If you have any questions, I'll be happy to answer that.
Well, thank you so much, Dr. Marulendra, for the shout out. You were very easy to work with, so I appreciate you volunteering your time to do this. It does look like you do have a couple questions in the Q&A. Can you see your Q&A?
Yeah,
if not, I can.
I believe I can. Let me see if I can click on it. All right. How long is the procedure and what kind of sedation do you use? Okay, so that's an excellent question. The procedure is typically a half an hour long. Some people can have, we jokingly say they have a highway, they have a relatively straight colon and no polyps, and we could be done in as little as 15 minutes. But as I said, roughly 1 in 3 to 1 in 4 people have polyps, and it takes time to be able to remove it carefully. See, in terms of polyp and polyp removal, the thickness of the wall of the colon is only about 3, maybe 5 millimeters, okay? We need to cut and remove at least 1 millimeter from under the surface of the polyp to prevent it from turning into cancer. But if you're not careful and we go a millimeter or more, it increases the risk of the colon bursting open. And that's why we take exceptional precaution, which takes time. So on an average, about half an hour for the colonoscopy. And in terms of sedation, so when I started back then, the standard sedation used to be what's called Versed and Demerol. Versed is like Valium. Demerol is similar to morphine. So it used to be a light sedative and a light pain control. But I would say over the past 10 years, propofol, which was unfortunately made popular for all the wrong reasons by Michael Jackson, it works much better. It works faster, better and safer degree of sedation in the right type of people, which is anesthesiologists or CRNAs. And also, they wake up much faster. With Versed, it tends to settle in their fatty tissue, and then they can have waves of weakness as the day progresses because the medication can be released back into their bloodstream. Whereas propofol has what we call a short half-life. In other words, once it goes through the bloodstream, it is inactivated quickly by the liver and excreted. As a result of it, they wake up typically within a half an hour. So the overall process is approximately 1 hour. But because you have to come in, you have to change, you have to get an IV in place, have the nurse and the anesthesiologist confirm that it's safe for you to have the procedure on the day, review all of your history and confirm that nothing was missed. All of those things, a total of approximately 3 hours. Now, because of the sedation, you need to take the day off, and you cannot drive home yourself. It is against state regulations. If unfortunately somebody's caught driving the same day, they can get a driving under the influence or DUI ticket. So they need to take the day off, but the next day they're able to resume their usual activities. Okay, so I hope that helped answer the first question. The second question is there any difference in the procedure if you get it done at a hospital versus a surgery center? So that is an excellent question. The answer is, short answer is no. In general, majority of the people who need a colonoscopy for screening are young, healthy individuals, typically between the age of 40 to, let's say, 75, perhaps even 80. So they are done at a surgery center. As far as the sedation, the monitoring, and the actual procedure, the technology, the scopes, it is all exactly the same. And I have to say proudly that Mercer County Surgery Center is the newest surgery center in town, and they have the latest of equipment. Unfortunately, some of the local hospitals have an equipment that's one generation behind what's available here. The only difference, though, is if somebody has a pacemaker, if they have significant heart disease, they have a recent stent or a coronary artery bypass grafting, or if their BMI is greater than 45, they cannot be done at the surgery center. They need to be done at the hospital. But as far as the procedure itself is concerned, it's exactly the same. Another point to remember, in general, hospitals' charges are about 3 times as much as that at a surgery center. So unfortunately, a lot of insurance company, to disincentivize you going to a hospital, they tack a higher copay or deductible if you get the procedure done at the hospital. And each person has to look at their health situation, see exactly what their benefits are, and you may even have to call your own 800 number to find out. But chances are your out-of-pocket cost will be lower at a surgery center compared to that in the hospital. Okay, so moving on to the next question. Have you ever personally had a patient who used Cologuard and missed a cancerous polyp? The answer is unfortunately yes. I've had it both ways, the way you point out, but we've had more patients, and it does become both a psychological issue for the patient and also potentially a medical legal issue down the road, where Cologuard came back positive, and with the most careful of tests, the colonoscopy comes back negative. Then comes the question, what do you do? Because polyps in other areas of the body don't cause a positive Cologuard test. So the question then becomes, was it a false positive? Or was there in fact a small polyp or even a small tumor that was missed? It's not a happy situation to be in, but that happens a lot more frequently, a false positive test, as compared to a person who had a cancerous polyp and the Cologuard missed it. The trouble is, we will truly not know this denominator for a long, long time, because it could be an additional 3 to 5 years before they develop a clinically significant colon cancer. And the way out for the Cologuard company is they say we guarantee it only for 3 years. So if unfortunately the patient develops colon cancer 3.5 to 5 years later, which is definitely feasible, they can get around by saying, well, you didn't have it 3 years ago. That is a technicality, medical legally speaking, that would put a patient at a disadvantage. All right, so the next question, and a very important question, do you need a consult first, or can I just schedule a colonoscopy? So the answer is you don't necessarily need a consult, though that's usually considered standard of care. Most people like to meet the person who's going to do a colonoscopy on them before they get the test done. It just gives them a little sense of comfort and relief to know the person, what type of person he or she is, the doctor, and not just that they're technically good at it. Okay, being a good human being, I still believe, is the foundation of becoming a good doctor. And to be able to communicate with the patients and to relate to them is extremely important. On the other hand, if it's a 45 to, let's say, a 60-year-old, no health history, no hypertension, diabetes, heart disease, lung or kidney disease, and if they wish to get set up for a colonoscopy nationwide, there is a program which is called Open Access Colonoscopy, where there are ways of the patients getting in touch with the doctor's office, securely filling out a form on the internet, and then either the physician or their assistant reviews to make sure that there's no health issue. We get a copy from the family doctor's office, and we are able to get them set up for a colonoscopy. In other words, an office visit is not mandatory. All right. So moving on to the next question. Let me see if my cursor works here. Uh, do you recommend endoscopy and colonoscopy at the same time? Okay. So as far as a colonoscopy is concerned, it is based on age and sometimes based on symptoms. Okay. Even if a person doesn't have any symptoms, if they're of the appropriate age, used to be 50, now it's 45, they need a colonoscopy. Endoscopy, for people who don't know what it is looking in through the mouth, down the food pipe, stomach, and small intestine. It's called an endoscopy, a upper endoscopy, or EGD is the other word. So in terms of EGD, unless they have symptoms, significant heartburn, upper abdominal pain, decrease in appetite, weight loss, food getting stuck or in the food pipe or throwing up blood, they don't need an endoscopy. So that's one way of answering that question. And the other is, can they be done together is another way of looking at it. And the answer is yes. Roughly 25 to 30% of the procedures we do is what we kind of jokingly call the double header. Both the upper endoscopy and colonoscopy are done in the same patient back to back. Especially in this age, I think it's very important. This means they don't have to have 2 COVID tests. They don't need to take 2 days off. They don't need to arrange for transportation to go back home on 2 different days, and only 1 set of sedation. So the answer is yes, it can be done on the same patient, provided there is the appropriate indication back to back or on the same day. Okay. And the next question is, do you do endoscopy as well? The answer is yes. Roughly 70% of the work we do is colonoscopy, simply because there are more people with the indication. I do endoscopy. I also do other advanced procedures that's called ERCP, not for today. My wife, Dr. Shiva Prasad, she's in practice with me, and she does even more advanced procedures called endoscopic ultrasound for early detection of pancreatic cancer. The final question, at least that's been posted so far, what type of scopes are used? As some time ago, I recall an issue with scope contamination. Any concern? So thankfully, I can tell you that with the type of scopes we use for the procedures that it's intended for, there has not been a single documented case of infection either here or at the hospital. The scope contamination issue that you have read about is for that special test called ERCP, where we need to go up into the bile duct to remove stones. Happened, unfortunately, especially in the Los Angeles area. There, the scope, because it has a side viewing port and other hardware, requires special cleansing, which it appears they unfortunately didn't follow, and led to some significant, even life-threatening infections. Thankfully, we have not had that documented in the 2 hospitals that I work at, which is Robert Wood at Hamilton and Penn Medicine at Princeton. Those are hospital-only procedures. They cannot be done at a surgery center. But as far as the EGD and colonoscopy is concerned, we follow the most stringent of cleaning precautions. Every single scope is tracked with every cleansing. The machine we use, which is called DSD, is the industry standard. And, you know, for example, at home, you're doing your dishwashing and you are able to open the front door and pull out a glass, for example, which is not totally clean. Here, once the scope is placed into the machine, till the cleaning cycle is complete, nobody can override it and remove the scope, and that is an additional precaution to prevent infection. In addition, Joint Commission, also known as JCHO, and the state, especially the state, can walk in on any day unannounced and ask that we show the log maintained carefully in terms of scope cleaning, and they can check, they can actually stand and watch the technician cleaning to make sure that it's done properly. So these are some of the safeguards that thankfully have prevented any type of infections associated with a scope at the surgery center. Unfortunately, if there should be any infection at all, typically it's related to IV site infection, but not scope related infection. I believe I covered all the questions, and look at it, it's 1 o'clock.
Yes, you have covered all of the questions at this point. So again, I thank you for taking the time to educate us on the colonoscopies, especially during COVID, and how important they remain. It was a very thorough explanation, so I do appreciate that. I learned a lot, and I'm sure the people who attended learned a lot as well.
Thank you. I appreciate
I'm going to go ahead and let you go now to get back to your patients. Thank you, everyone, for joining us today. We look forward to seeing you next time. Enjoy your afternoon.
Thank you. Have a wonderful day, everybody. Bye-bye.